Okay, hello everyone. Thank you all so much for joining us today. My name is Christina Feather-Stolitka. I am a health IT advisor here at the Kentucky Regional Extension Center, and I'll be presenting today's slides on the Medicare Promoting Interoperability Program for hospitals. First, I'm going to highlight the 2023 IPPS final rule. I'm going to cover the Stage 3 requirements for 2023, touch on a few action items and reminders, and then finish up with the most recently released IPPS rule, the 2024 proposed rule. So as a refresher, let's take a look at what CMS finalized in the 2023 IPPS rule. So as a reminder, the inpatient prospective payment system rules are how CMS makes revisions to their programs. Got some pop-up windows here. Bear with me a second. Okay, there we go. All right, so as a reminder, the inpatient prospective payment system rules, these are how CMS makes revisions to their programs each year. So they update payment policies and the annual payment rates for the Medicare prospective payment system, provide new performance standards for the hospital value-based purchasing program, update policies for the hospital readmissions reductions program, and the hospital inpatient quality reporting program, among many others. It also establishes new requirements and revises existing requirements for hospitals participating in the Medicare Promoting Interoperability Program, which, as you all know, is my focus, and that is the section that I'm going to highlight for you today. So on this slide, I've included links to the fact sheet and the final rule. Now, this is the rule that was finalized back in August, and at that time, many of us were still focused on finishing program year 2022, but now that we're nearly halfway through 2023, and many of these changes included in the 2023 IPPS rule impact this program year, I wanted to go ahead and include this information as a refresher. So this slide provides us with a snapshot of the changes specific to the Medicare PI program in this program year, 2023. So I'm going to spend some time on this one, and I'll go in order here. First up, CMS is requiring the electronic prescribing objectives query of prescription drug monitoring program measure while maintaining the associated 10 points and modifying the measure to include Schedule 2, 3, and 4 drugs beginning in 2023. So CMS said that PDMPs play an important role in patient safety by assisting in the identification of patients who have multiple prescriptions for controlled substances or may be misusing or overusing them. They believe that expanding the requirements of the query of PDMP measure to include not only Schedule 2 opioids, but also Schedule 3 and 4 drugs, this would further support HHS initiatives related to the treatment of opioid and substance use disorders by expanding the types of drugs included in the query of PDMP measure, while also aligning with the PDMP requirements in a majority of states. They believe this expansion to include additional scheduled drugs will facilitate more informed prescribing practices and ultimately improve patient outcomes. Next up, CMS added a new option to the Health Information Exchange objective, the enabling exchange under the Trusted Exchange Framework and Common Agreement, or TEFCA measure, as an optional alternative to fulfill the objective beginning in 2023. So this year, hospitals will have 3 reporting options for the Health Information Exchange objective. Report on both the support electronic referral loops by sending health information measure and the support electronic referral loops by receiving and reconciling health information. Option 2, reporting the HIE bidirectional exchange measure, or option 3, reporting the enabling exchange under TEFCA measure. This next one includes some very significant changes to the program. CMS has consolidated the previous options for the public health and clinical data exchange objective from 3 to 2 levels of active engagement. And they are now requiring that hospitals submit their level of active engagement for the measure under the objective beginning this year, 2023. As a reminder for everyone, back in 2016, CMS established a definition for active engagement under the public health objective. Active engagement was defined as when a hospital was in the process of moving towards sending production data to a public health agency or clinical data registry, or was sending production data. And they established 3 options. Option 1, completed registration to submit data. Option 2, testing and validation. And then option 3, production. According to CMS, the 3 active engagement options provided flexibility for hospitals to meet the measures under the public health and clinical data exchange objective in a variety of ways, but they did not provide an incentive to move through the options to get to option 3, production, where there is actually ongoing electronic submission of data. So now many years have passed. CMS believes that hospitals have had ample time to complete option 1. So they've consolidated options 1 and 2 into one option beginning this year. And it will be called pre-production and validation. And they are renaming the previous option 3 as validated data production. CMS said that their continued goal is that all hospitals will be at the validated data production options, as successful exchange of data is needed because that's where that data can be utilized to combat current and future public health emergencies. Also, as part of the changes to this objective, hospitals were previously not required to report their level of active engagement for any of the measures, but during the COVID-19 public health emergency, CMS further recognized the importance of public health reporting and believed that knowing the level of active engagement that a hospital selects will provide information on the types of registries and geographic areas with healthcare providers in the pre-production and validation stage. Therefore, hospitals will now be required to submit their level of active engagement, either option 1, pre-production and validation, or option 2, validated data production, for each measure that they report beginning in 2023. Moving on next to scoring, CMS modified the scoring methodology for the Medicare PI program beginning in 2023 by increasing the points value of certain measures and decreasing others. And then lastly on this slide, CMS finalized changes to the clinical quality measures in alignment with the hospital inpatient quality reporting program by adopting 2 new ECQMs to the measure set. The severe obstetric complications and cesarean birth ECQMs are voluntary in 2023, but policy states that they will become mandatory in 2024. And then also in alignment with the IQR program beginning this year, CMS is also going to require 4 quarters of data to be submitted. Also, just keep in mind that as part of this rule, CMS already finalized some changes to the program for next year. So taking a look ahead, CMS is adding and requiring an antimicrobial use and resistance measure to the public health objective, in addition to the 4 required measures: syndromic surveillance, immunization registry reporting, electronic case reporting, and electronic reportable lab result reporting. And that's beginning in 2024. CMS stated that the antimicrobial resistant infections are caused by pathogens that no longer respond to the drugs designed to kill them and directly threaten patient and population health. An effective national response to the threat presented by antimicrobial resistant bacteria requires robust systems for collecting, analyzing, and using antimicrobial use and resistance data to direct action. CMS believes that requiring an AUR measure under the Medicare PI program will enable the development of a true national picture of the threat posed by antimicrobial overuse and resistance. Requiring AUR reporting will produce inpatient benchmarks that can be used to guide clinical and public health action. Also regarding the public health objective, and this one is huge, beginning in 2024, CMS will require hospitals to limit the duration of their time on option 1 of active engagement to a single reporting period. For example, if a hospital submits a level of active engagement at option 1, and remember that's now pre-production and validation, for the electronic case reporting measure in 2024, then the hospital must move to and report a level of active engagement at option 2, validated data production, for the next reporting period for the electronic case reporting measure. So 2025 in this example, or it would fail to satisfy the public health objective. Their goal is for all healthcare providers nationwide to be at the validated data production stage so that data will be actively flowing and public health threats can be monitored. CMS originally proposed this to begin in 2023, so we're grateful they delayed this requirement by 1 year. CMS stated that this delay balances the urgent need to move hospitals into data production with the need identified by commenters for additional time for public health agencies and healthcare providers to prepare for this change. Without this requirement, facilities can linger in registration and testing or validation for years, which provides little benefit to the public in a public health emergency or to address health threats. And I flagged this one because if you're a hospital who's been working on a public health measure for a few years now, like maybe you're stuck in testing or you're getting through by having your KHI addendum signed, you're getting a not so gentle nudge here by CMS to move forward into production. And I know that this is going to impact a lot of hospitals. And then lastly, here are some additional changes coming next year in regard to ECQMs, adopting 2 new measures, and modifying the submission requirements from 4 to 6. Okay, now let's go ahead and take a deeper look at all of this year's requirements. And I'm not going to spend a lot of time on looking back, but as you all know, the American Recovery and Reinvestment Act of 2009 mandated that CMS incentivize hospitals to adopt, implement, and upgrade certified EHR technology and demonstrate meaningful use. In response, the EHR Incentive Program, formerly known as Meaningful Use, was introduced in 2011 under the Health Information Technology for Economic and Clinical Health Act, or the HITECH Act. CMS implemented the program in progressively more difficult stages and initially offered incentive payments to do so. Those incentives continued through 2016 for most hospitals, depending on which year they started in the program. And although the incentive phase of the program ended long ago, hospitals must continue to participate in the program each year to avoid a downward Medicare financial adjustment. As we progressed through stages 1 and 2, modified stage 2, and now stage 3, CMS has maintained their underlying focus on the adoption and implementation of CERT through an evolution of objectives, measures, and ECQMs tailored to meet their goals. More recently, CMS overhauled the program, improving flexibility, relieving burden, and placing emphasis on measures that require the electronic exchange of health information between providers and patients. They really shifted their focus to interoperability and improving patient access to health information. These changes moved the program beyond the previously existing requirements into a new phase of EHR measurement. The Medicare Promoting Interoperability Program, as you know it today, includes a set of objectives, measures, ECQMs, and other requirements that together define whether an eligible hospital or critical access hospital has met the minimum standards to be considered a meaningful user. Those hospitals not meeting the minimum program requirements, meaning they're not meaningful users of CERT, they receive downward payment adjustments. And remember, unlike other programs, the Medicare PI program for hospitals has no defined end date. So in 2023, the reporting period is again a minimum of any continuous 90-day period. Looking ahead, the EHR reporting period will increase from 90 to 180 days, but not until calendar year 2024. In addition to reporting the required objectives and measures, hospitals must also submit 4 calendar quarters of data for 4 electronic clinical quality measures. Beginning in calendar year 23, this year, eligible hospitals are now required to use the 2015 edition Cures update criteria in order to meet the CERT definition. Hospitals must provide their EHR CMS identification code from the Certified Health IT product list, often referred to as the CHAPL or the CHPL. It's available on healthit.gov, and that must be provided when submitting your data. The security risk analysis measure continues to remain a requirement of the Medicare PI program, as it is imperative in ensuring the safe delivery of patient health data. Hospitals must conduct or review a security risk analysis of CERT, including addressing encryption and security of data, and implement updates as necessary at least once each calendar year, and attest to conducting the analysis or review. And it is acceptable for the SRA to be conducted outside of the EHR reporting period, but it must be within the calendar year. And keep in mind, while it remains a requirement of the Medicare PI program, it is not scored, but a yes or no attestation is required. Hospitals must also attest to the safety assurance factors for EHR resilience or safer guides measure. CMS will continue to implement the same performance-based scoring methodology. A total score of 60 points or more will be required to satisfy the scoring requirement and successfully attest. And then lastly, the attestation submission deadline for program year 2023 has already been set, and that is February 29th, 2024. And I want to spend a little extra time on this one since this requirement is newer. CMS added the Safer Guides measure to the Protect Patient Health Information Objective last year, supporting the Medicare Promoting Interoperability Program's goal of improved EHR use and healthcare quality. So the Safer Guides are designed to help healthcare organizations conduct self-assessments to optimize the safety and safe use of EHRs. Hospitals will be required to submit a yes or no for completing an annual self-assessment during the calendar year using all 9 Safer Guides, and those are available from healthit.gov. To complete each self-assessment, hospitals are expected to fill out the checklist and practice worksheet at the beginning of each guide. Each of the 9 Safer Guides begins with a checklist of recommended practices. The downloadable Safer Guides provide fillable circles that can be used to indicate the extent to which each recommended practice has been implemented. Following the checklist, a practice worksheet gives rationale for and examples of how to implement each recommended practice, and fillable fields to record team members and follow-up actions. Each Safer Guide also includes an interactive references and supporting materials. For 2023, this attestation will be required, but similar to last year, the yes or no attestation response will not affect a hospital's total score for the program. An organization does not have to confirm that it has implemented fully in all areas each practice described in a particular Safer Guide, nor will an organization be scored on how many of the practices the organization has implemented. The Safer Guides are designed in part to help deal with safety concerns created by the continuously changing landscape that healthcare organizations face. Changes in technology, practice standards, regulation, and policy should also be taken into account when using the Safer Guides. Okay, here we go. For 2023, hospitals are required to report on 4 objectives. This slide provides a basic overview of the points distributions broken down by measure. Electronic prescribing, so generating and transmitting permissible prescriptions electronically for up to 10 points, and the query of PDMP measure is no longer a bonus measure, but required this year and worth up to 10 points. And remember, CMS is no longer limiting PDMP to Schedule II opioids. Schedule III and IV drugs are included. I'll also just add regarding the PDMP measure, CMS requires the query of the PDMP for prescription drug history to be conducted prior to the electronic transmission of the prescription. So given the variance in state level requirements and actions used to perform the query, healthcare providers do have flexibility to satisfy this measure by querying the PDMP in any manner legal and practicable in their state. The measure does not specify whether a provider's cert connects to PDMPs directly, but documentation should be retained on policies and processes to support the measure. So overall, you want to have evidence that you have the functionality in place to support this measure, that you performed the action that CMS requires, and that you did so during the reporting period. All right, health information exchange encourages and leverages interoperability and promotes health IT-based care coordination. There are 3 options this year: the support electronic referral loops by sending and by receiving and reconciling health information, or one of the alternate measures, the engagement and bidirectional exchange through health information exchange, or the new enabling exchange under TEFCA measure. The first option, the sending and receiving measures, they are both numerator-denominator submissions worth 15 points each. Option 2, bidirectional, is a yes or no attestation, and there are 30 points for that measure. And then option 3 is also a yes or no attestation with 30 available points. And you only have to choose one of these 3 options to meet the program requirements. Next is the provider to patient exchange objective, so giving patients electronic access to their health information. Reporting is by numerator and denominator. There are no new updates to the measure itself except the scoring. It's worth up to 25 points. And then lastly, the public health and clinical data exchange objective. These are the measures that a hospital attests yes to being in active engagement with a public health agency or clinical data registry to submit electronic public health data in a meaningful way using their cert. Hospitals must report on the 4 required measures: immunizations, syndromic, electronic case, and electronic reportable labs for 25 points. And remember, as I covered earlier, new for 2023, CMS will require hospitals to report their level of active engagement, and those options have been consolidated and renamed. There are 5 bonus points available for those who choose to submit the public health or clinical data registry. You only have to choose one. You don't have to submit for both. And it's 5 points altogether, not 5 per bonus registry chosen. And most Kentucky hospitals have been meeting these public health measures through KHI, the Kentucky Health Information Exchange, and will be able to continue doing so. For our Kentucky hospitals, if you have questions regarding your hospital's public health reporting status, I recommend that you contact your KHI outreach coordinator, and I would be happy to help you get in touch with them if needed. Okay, so moving on now to clinical quality measures. So to successfully participate in the Medicare PI program, CMS requires hospitals to report on electronic clinical quality measures. These ECQMs are selected by CMS and require the use of certified EHR technology. The ECQMs are tools that help measure and track the quality of healthcare services provided by hospitals. These measures use data reported from EHRs that are associated with healthcare providers' abilities to deliver high-quality care or relate to long-term goals for quality healthcare. ECQMs help ensure that our healthcare system is delivering effective, safe, efficient, patient-centered, equitable, and timely care. There are no performance thresholds to meet, but the CQM data must be reported exactly as generated by the hospital's cert and submitted electronically through the hospital quality reporting system using any combination of QRDA Category 1 files, zero denominator declarations, and/or case threshold exemptions. In 2023, hospitals are required to report on at least 3 ECQMs and the safe use of opioids concurrent prescribing measure for a total of 4 ECQMs. The reporting period for hospitals that report ECQMs in the Medicare PI program is the full year, so 4 specific calendar quarters of data. I'll also note that fulfilling the ECQM requirement for the Medicare PI program through electronic reporting also satisfies the ECQM reporting requirement for the hospital inpatient quality reporting program, because year after year, CMS does continue to align these 2 programs. The table on this slide showcases all ECQM options available to report on in 2023. Again, the safe use of opioids concurrent prescribing measure is required this year, aiming to reduce preventable mortality and the costs of adverse events. The severe obstetric complications and cesarean birth ECQMs are optional for self-selection in 2023, but in 2024, they will become mandatory. Okay, moving on to scoring now. While the weights of some measures have changed slightly from last year, the methodology is similar. Hospitals are required to report certain measures from each of the 4 scored objectives, with performance-based scoring occurring at the individual measure level. Each measure is scored based on the hospital's performance for that measure, except for the yes or no's. The scores for each of the individual measures are then added together to calculate the final promoting interoperability score, which is capped at 100 possible points for each hospital. In 2023, a total score of 60 points or more will satisfy the CMS requirements. Hospitals scoring below 60 points will not be considered meaningful EHR users and will be subject to Medicare payment reductions. And remember, hospitals must report on all of the required measures in order to earn any score at all. If you submit a 0 in a numerator or denominator, or report a no for a yes or no required measure, you would not meet the requirements and would earn a total score of 0 for the PI program and be subject to a downward payment adjustment. So again, just to be clear, in order to earn a score greater than 0, hospitals must complete the activities required by the security risk analysis and a safer guides measure, submit their complete numerator and denominator and yes/no data for all of the required measures, submit their level of engagement for the public health and clinical data exchange measure, attest to the actions to limit or restrict the compatibility or interoperability of cert statement and the ONC direct review attestation, as well as report on the required electronic clinical quality measure data. So let's go ahead and talk about those payment adjustments. The legally mandated penalties under the HITECH Act continue to remain in effect, and that's why success in this program is so important. I've always found it interesting how CMS describes participation in these programs. They describe it as eligibility, an eligible hospital, an eligible participant. And I guess that's their nice way of saying mandatory, because you don't really have a choice unless you want to be penalized. So all hospitals must continue to successfully attest to the Medicare PI program each and every year in order to avoid an annual downward payment adjustment. The eligible hospital payment adjustment is applied as a reduction to their inpatient payment rate for that corresponding year, and the critical access hospital adjustment is applied to the Medicare reimbursement for inpatient services during the cost reporting period in which the CAH failed to meet program requirements. Okay, now let's review some action items and reminders for 2023. This slide provides a good summary of what I've covered today for program year 2023 and an overview on timelines. The reporting year began on January 1st, and it will end on December 31st. During the entire calendar year, eligible hospitals and critical access hospitals may choose any consecutive 90-day period as their chosen EHR reporting period. It does not need to be a specific quarter, and you can certainly report to a longer period, up to and including the full year, but it must be at least a minimum of 90 days. Hospitals must attest through the CMS Hospital Quality Reporting System. Usually those attestation screens open up during the first week of January. The attestation submission deadline, as I already mentioned, is set for the end of February 2024. This participation checklist, I think, is also a great resource and summarizes the program very well. So for 2023, hospitals are required to report on all 4 PI objectives for a minimum of any continuous 90-day period using the 2015 edition cures update criteria in order to meet that cert definition. Hospitals must report on 3 self-selected ECQMs in the safe use of opioids concurrent prescribing measure for the full calendar year, submitting 4 quarters of data. And lastly, on this checklist, hospitals must conduct or review a security risk analysis during the calendar year and complete the Safer Guides measure. And as a quick reminder, you can find all of the Safer Guides on that ONC webpage. So for the measure itself, there are no changes for 2023, but again, the hospital will attest to whether or not they've completed a self-assessment on all 9 of the Safer Guides. And yes or no are both acceptable. So CMS requires that you attest, yes, we completed the self-assessment, or no, we did not complete the self-assessment. The yes and no are both acceptable. No does not mean any kind of penalty. And remember, the self-assessment does not need to be completed during your chosen reporting period. You can work on the assessment throughout the year. I also want to remind everyone that CMS has instituted public reporting on certain Medicare Promoting Interoperability Program data beginning next month. CMS believes a hospital score for the Medicare PI program constitutes relevant data because it will help consumers make informed decisions regarding their healthcare team, such as knowing whether and to what extent their healthcare provider is involved in health information exchange, or providing patients with electronic access to their health information. CMS stated that publicly reporting PI data demonstrates their commitment to providing data to patients, consumers, and healthcare providers to assist them in their decision-making, promoting enhanced HIE processes across hospitals, and continually aligning policies with the hospital IQR program and the MIPS PI performance category on the ambulatory side. So new in 2023 is the public reporting of certain hospital information, which will be posted on the Care Compare website. So the name of your hospital, your CCN, your total score will be made public. And CMS has noted that this data will be pulled directly from your PI submission, so it's even more important that the information you submit is accurate because, as a reminder, you are not able to edit your PI submission once the attestation deadline has passed. All right, that brings us to our last section today, which is the 2024 IPPS proposed rule. This is the most recent rule issued by CMS. The 2024 IPPS proposed rule was released on April 10th. It's currently open for review and comment period. And if they follow suit with prior years, we expect this rule to likely be finalized in August. So as proposed, CMS wants to modify the requirements for the Safer Guides measure to require hospitals attest yes to having conducted those Safer Guides beginning in 2024. They've also proposed a minimum of any continuous 180-day reporting period in 2025, and then adopting some new ECQMs as well. And keep in mind that with the proposed rules, what CMS ultimately finalizes may end up being different from what they initially proposed. Okay, we're nearing the end of our time together today, but before I wrap up, I want to share how we at the Kentucky REC can help your hospital meet your PI goals. So clients receiving our hospital PI services get ongoing guidance and attestation assistance. We really act as experts on call, meaning you have access to us whenever you have questions, need clarification, or require advice. This includes meetings to always make sure you're ahead of the attestation process, timelines, deadlines. You'll receive proactive timely alerts from us regarding the constant program updates and policy changes, so you'll always have the most up-to-date information. We keep our client hospitals updated on future rulemaking as well. So for example, as I just mentioned, we expect CMS to release that 2024 IPPS final rule later this summer. We get that information out to client hospitals right away. We present the material via client-only webinar and review the specifics individually. We have been a trusted resource for many years now, providing unbiased and vendor-neutral advice to Kentucky hospitals, along with audit prep and support services. And lastly on the slide, and I think most importantly, we provide you with customized education. This program is a lot to keep up with, and we realize that you're often wearing multiple hats within your facilities. This is solely what we do. We provide detailed reviews of all the promoting interoperability requirements, the objectives, measures, CQMs, and again, the proposed and final rules. So as a client, you'll receive the constant need to know information, so you're not going at it alone. And we also help to monitor your hospital's reports and complete gap analyses to assess your status in the program and estimate your projected scoring. Our stage 3 gap analysis tool gives a good visual of where you're at, and then the dashboard helps to track trends in your data over time at the individual measure level, helping to ensure that you're meeting or exceeding the mandated requirements and avoiding those costly penalties. We host client-only webinars and have frequent conference calls and meetings. We can use that time to answer questions and provide clarifications on program requirements. We have some hospitals that schedule with us as needed, and then others that have standing recurring meetings set up. This service can really be customized to meet your individual needs. So if we don't already work with your hospital, we would love the opportunity. So please contact me after today's webinar and we can talk through the specifics of your hospital's needs and how the Kentucky RAC can help. And I know I ran us a few minutes over, so I appreciate you bearing with me. But with that, I sincerely thank you all for your time and attention today. If you have any comments, concerns, questions about today's presentations, or any of the requirements for program year 2023, please email them to my colleague, Robin Kernel, or myself, or give us a call. Okay, have a great afternoon. Thanks, everyone.